Welcome to this webinar that is presented by the American Liver Foundation's Connecticut Division. The American Liver Foundation's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. There are 17 divisions of the American Liver Foundation throughout the country. Our website has a wealth of information for anyone looking for information about a wide variety of liver-related diseases and treatments. We also have a helpline that can be reached Monday through Friday from 9 a.m. to 7 p.m. That number is 1-800-GO-LIVER or 1-800-465-4837. Today's webinar is entitled Understanding Cirrhosis and Optimizing Treatment. We wish to acknowledge and thank Yale New Haven Health for sponsoring this webinar. Our presenter is Dr. AnnMarie Liapakis, Associate Professor of Medicine, Digestive Diseases, and Transplant Surgery at Yale. Dr. Liapakis is a graduate of Fordham University and Albert Einstein College of Medicine. She is also a member of the Board of Directors of the American Liver Foundation's Connecticut Division, and she serves on its Medical Advisory Committee. She will offer information about cirrhosis and treatments. Dr. Liapakis, thank you for presenting today.
Thank you, Donna. I appreciate the opportunity today to present this webinar. I hope that it will be a useful tool for our patients, their families, and care partners. The objectives are to relay to our patients so that they may learn the facts, not the myths and misconceptions that are often circulated regarding liver disease and cirrhosis, to gain a better understanding of advanced liver disease so that you may partner with your care team to optimize your treatment, to engage your family and friends, to learn about your symptoms and be aware of warning signs that require urgent attention, to increase your support and avoid emergencies, and to be aware of the indications and appropriate timing for liver transplant. Okay, so let's start by talking about what the liver does. The liver is an organ that sits in the right side of the abdomen, just under the lower rib cage, and it does a number of important jobs in our bodies. It acts like a factory producing proteins. One of those is albumin. Albumin is involved in building muscle mass, and it's actually a test that we can measure in the blood work. The liver is also involved in making most of the blood clotting factors, so that if you cut yourself, your body ultimately forms a blood clot. It's the liver that made a lot of the proteins that allowed you to do that. The liver produces a number of vital substances. One of those is bile. Bile is made in the liver, stored in the gallbladder, and released into the intestines when we eat to help digest fat. The liver also is involved in making cholesterol. It stores substances and replaces them when needed. For example, when we're fasting, it can release sugar back into the bloodstream, stores a number of vitamins. It also acts as a part of our immune system to help fight off infections. And the liver breaks down certain materials. Some of those may be prescribed medications, alcohol, caffeine, and it filters toxins from our bloodstream. So what is hepatitis? I want you to understand that hepatitis means nothing more than inflammation of the liver. Sometimes people hear hepatitis and there's a lot of misinformation out there that makes it scarier than it really is. It really is inflammation of the liver, and it can have a number of different causes. Just like there are many causes of kidney disease or heart disease, for example, there are many causes of liver inflammation or liver disease. Some of the broad categories are viruses such as hepatitis B and C, certain inherited diseases that may lead the body to store excess iron or copper or make abnormal proteins like alpha-1 antitrypsin, autoimmune disease where the body may inappropriately create inflammation targeted against the liver, alcohol in heavy quantities, fatty liver disease, which is not mediated by alcohol but may be associated with obesity, high blood sugar, high cholesterol, high blood pressure. Certain medications may have unintended side effects of causing liver inflammation, blood clots, heart disease, celiac disease, and some others. what is the progression of liver disease is I like to think about it with maybe a silly analogy, but let's think about if you have something that's irritating your skin and you scratching, ultimately you're going to get a scar there. So it's a similar thing with hepatitis. If you have inflammation in the liver and that goes on over time, it ultimately leads to scarring in the liver. And the fancy word that we use for that is fibrosis, and that scar tissue of fibrosis may ultimately replace normal liver cells. And when the fibrosis progresses to the point where it's really a lot, that's when we use the word cirrhosis. So, cirrhosis is a word that is used to describe an advanced stage of non recoverable liver scarring. And I just want to summarize that again here with this slide. So you have hepatitis or liver inflammation, which when it progresses over time leads to fibrosis or scarring. And we can actually quantify the amount of scarring in a number of different ways, but the classic way is was with a liver biopsy, where we could actually see, is there a little bit of scar tissue there, a moderate amount, moderate to severe, or a lot. And we have a number system that we use to describe it. And that number has nothing to do with cancer. It's just a way that if I look at a liver biopsy and I try to describe to somebody else how much scarring is there, that we have a system to do that. So cirrhosis means stage 4 scarring, or at that point, patients usually have so much scar tissue that the liver is more nodular rather than smooth. I sometimes worry that people have this idea that you can remove the cirrhosis or the part of the liver that's scarred, but it doesn't really work like that. The scarring is generally homogeneous or the same throughout the liver. Um, when you have an earlier stage of scarring, if you address the liver disease, i.e., which is causing inflammation, and you stop it, then you can actually stop the scarring at that point. Um, but when you've gotten to the point of cirrhosis, usually you're not able to resolve that scarring. And the next thing that we have to understand is that there are stages of cirrhosis. Um, so one is compensated, and what that means is that the liver is very scarred to the point of cirrhosis, but the liver is still working well, and a person has no signs or symptoms that their liver is sick. And a person with compensated cirrhosis may live a normal lifespan and die from something else. The goal there is to eliminate the liver disease and stop the scarring there so that a person doesn't wind up with decompensated cirrhosis, which we'll talk about now. Decompensated cirrhosis means that the liver is very scarred to the point of cirrhosis, and now it's affecting somebody's health and living. They have signs or symptoms that their liver is sick. And the way that I think about it is that there are three things that may happen, and it may be one of them, two of them, or all three. And we're going to take some time now going through that. One is that a person may develop a liver cancer. They may develop liver dysfunction or evidence that the liver is not working or able to do its job to the maximum. Or they may develop complications of something called portal hypertension, which is sort of a high blood pressure around the scarred liver. So first we'll talk about liver cancer. A liver cancer may happen more commonly in the setting of cirrhosis. It does not generally happen in the setting of somebody with a healthy liver, unless it's metastatic, having started somewhere else. The important thing is that if a liver cancer is found early, more effective treatment can be offered with a potential for cure, and transplant may actually be an option for curative treatment. So because of this, we do screening for patients who have cirrhosis. And that screening is to take a picture of the liver every 6 months. And that may be either through ultrasound, CAT scan, or MRI. And there are different benefits from using either technique that can be reviewed with your physician to make a decision about what's the right option for you. But the important thing is to have a test done every 6 months so that if something does develop, it can be addressed timely. So we'll move on to liver dysfunction. So this means some degree of liver failure, that the liver is no longer doing its job 100%. So this goes back to what we talked to in regards to what the liver does regularly. So it may not be making proteins to max capacity, and patients may suffer from muscle loss or low albumin in their blood work is a marker of that. They may have a tendency to easy bleeding, and we can see a high bleeding time, something that's called the INR blood work, which may reflect that. Bile may no longer flow well through the scarred liver, and you can have a backup. And people may become jaundiced with yellowing of their eyes and skin, and we can see a high bilirubin level on the blood work. You may suffer with low blood sugar, which we refer to as glucose, and may be prone to infections and may not actually present with typical signs of fever. So we have to have a very high suspicion if something's not going right, if you're not feeling well, that it may be an infection and the doctor should be alerted to do a look for that. So we actually have an objective way of measuring liver function. It's with something called the MELD score, MELD, which stands for Model for End-Stage Liver Disease. It's actually a math formula which uses laboratory test results. So bilirubin, INR, for the reasons that I just mentioned, and also creatinine, which is a measure of kidney function, because sometimes when the liver is so sick, the kidneys get sick as well. And then sodium, because as we'll talk about in a few minutes, when the liver is very scarred, you may have water retention, and that can make the blood sodium seem low. But I want people to understand that that doesn't mean that you should take in more salt. It's actually the opposite, and we'll talk about that. So you take those 4 blood test results, bilirubin, INR, creatinine, and sodium, and put them into a math formula, and it gives you a result. The range is 6, which is the lowest. Even a person without liver disease will score a 6 just because of the way that the formula is set up. And then the number can go higher than 40, but when a person, for example, is on a liver transplant waiting list, 40 is the cap. And this is used to prioritize patients for liver transplant because it actually predicts survival. So the higher the score is, generally the sicker the person is. And for example, a person with a score of 40 has nearly 100% chance of dying over the next 3-month period. And that's why they're placed at the top of the list if they're awaiting transplant. So now I'm going to move on to the third thing. We talked about cancer, we talked about liver dysfunction. Now we're going to talk about portal hypertension. So what does that mean? That means a high blood pressure around the liver. And the way that I like to explain it is to think about a traffic jam. So imagine you're on the roadways and all of a sudden you come up into traffic. What happens? The cars stop and they're backed up, and they back up into the incoming roadways. And people feel frustrated and tense, and they try to get off the road and find a different route around the traffic jam. And so that's similar to what's happening when a person has cirrhosis and portal hypertension. What you see is that the blood is trying to flow into the liver through the main vein called the portal vein, but because the liver is scarred, it can't flow well, and that creates sort of a traffic jam in the liver. And what you see is that the blood actually backs up into the incoming veins. Um, and the body can try to find different roadways to bypass the liver. And so what happens is you may have a backup of blood to other veins, such as that to the spleen. And people may have enlargement of the spleen on the left side of their body. In that setting, they may actually see low blood counts on the blood work because the spleen tends to consume white blood cells, red blood cells, and platelets when it's enlarged. And believe it or not, the body can create new veins to try to reroute the blood. And those veins may be in the stomach, or they may be in the esophagus or food pipe. And those are varicose veins. They look like varicose veins, which someone may have on their legs, for example, but they're there for a different reason. They're there because of this high pressure around the liver and the body's attempt to try to offload that blood flow. Um, but unfortunately, varices may be dangerous. And I'm going to now talk through some of the complications that you may see related to this high pressure. And we'll start with varices. So, varices, again, are veins that may be around and in the esophagus and stomach, which become enlarged and may be prone to rupture and bleeding because of the high tension within them. The varices may be small, medium, or large size, but it's the larger size varices that have a higher risk for bleeding. And it's important for you to know that bleeding may present as vomiting or spitting up blood, but it may also present with dark or tarry looking stools or poop. And we call that melena. We see that because as the blood is digested, as it travels through the GI tract, it becomes that sort of black color. And if ever you notice signs of bleeding, the important thing to realize is that's an emergency and it requires treatment right away. It's a reason to call 911 or to present to the emergency room and alert your doctor. Um, all patients with cirrhosis should have screening to look for these varices because if we find them, then we can institute measures to try to prevent bleeding from happening in the first place. And we'll talk now a little bit more about that. So the pictures on the screen here, what you see is at the time of endoscopy when the doctor is looking with a little light and camera into the food pipe or esophagus and stomach. So it looks like you're looking down a tube because that's what the food pipe esophagus looks like. But what you see is these veins coming into the middle of the screen. And those are the varices. And these would be moderate or large size. What we do is we put air in during the procedure, and if they flatten out, we consider them small. But if they don't flatten out and they remain sort of engorged like this, or they have red spots which indicate a higher risk of bleeding, then we need to take a measure to prevent a bleeding episode. And we have two choices. We can use a medication called beta blockers. And those medications, what they do is they reduce the heart rate and the blood pressure to reduce the pressure in the veins. And I've listed on the slide here some of the names of the beta blockers that we use. For example, nadolol, propranolol, carvedilol. When we use them, the goal is to use a dose that results in the heart rate being reduced down to about 55 to 60 to know that we've really had an effect, that we're doing something to be protective. And sometimes we can get there to that goal, but sometimes we can't because we may see that the blood pressure is dropping too low or a person has side effect from the medication. And then we have to do something else, which the option would be to do banding. Now, banding means that at the time of endoscopy, the doctor actually puts a little suction on, pulls the vein up, and then fires off a band, which is a very tiny rubber band around the vein. And that's the picture, the second picture on the screen here. Now, what happens is once those bands are placed, then the vein starts to scar away. And when the vein scars away, ultimately the band falls off and you poop it out, but you don't see it. It's so tiny. Sometimes people have the idea that the bands are there forever. They're not. They do what they're supposed to do and then they fall off. There is some risk of bleeding around that time because generally there's a very clean based ulcer there that heals. But if there's a tiny blood vessel in that ulcer, that may result in bleeding. So if ever you have banding done and you notice bleeding or that dark stool again, usually around a week to 10 days out, that's something to alert the doctor about. So what we do is we do these banding sessions every 2 weeks until the veins are gone, and then we can check again 6 months later. So this is done to help prevent a bleed. If somebody has already had a bleeding episode, we do both things. We use the medications and do banding. I'm going to move on now to talk about something called ascites. Ascites is fluid buildup in the belly or abdominal cavity, and it's another complication of portal hypertension. It results from that high pressure and also the fact that you may have low albumin levels, and so the blood vessels are a bit more leaky because you don't have as much protein holding the blood or fluids where they should be. So people develop this fluid, and this is a picture of a CAT scan where you can see the fluid is the dark, which is around this scarred liver, which looks nodular or lumpy and bumpy. A person may also have fluid build up in their chest around the lungs, and when it's located there, we call it a pleural effusion. Um, so this fluid may unfortunately become infected, and when it is, we call that spontaneous bacterial peritonitis, or SBP for short. So the goal is try to get the fluid under control so that there's not a risk of that happening, or so that a person is not struggling with fluid buildup in their belly or shortness of breath. So how do we treat ascites? The first step is usually salt restriction. That can have a major impact because if you take in too much salt, then water follows it, and you just have this vicious cycle of more and more fluid buildup. So the goal for patients with cirrhosis is to try to keep salt intake to less than 2,000 milligrams of sodium per day, or 2 grams. And the best way to try to do that is to read labels, because you may not be aware of high salt content in some of the foods unless you look. So some things that are notoriously high are deli meats, um, TV dinners, canned soups, Chinese food, pizza. So those things really should be avoided. And then, of course, not adding additional salt from the salt shaker at mealtime. If salt restriction itself is not enough, then what we do is we use water pills. We call them, they're diuretics. And what they do is they help the kidneys to excrete more salt and water. And I've listed out the names of some of them here. Um, and the thing to know is that some of the water pills will actually cause the body to lose potassium. So some of these top ones here um, can lead to a lower potassium level. And then some of them will actually cause the body to hold on to potassium, the lower ones listed on the screen here. And so we often will use 2 water pills in a certain ratio and adjust them until we get it right. We generally will start at a low dose and see what dose the kidneys respond to, at which point you start urinating more, and we may need to increase the dose. And it's a delicate balance between trying to get that extra fluid off, but avoiding dehydration and avoiding causing any problems for the kidneys. So it involves monitoring weight, monitoring lab tests to check sodium, which is Na, potassium, which is a K, and creatinine, which is a CR. You'll see these results on your blood work. And so we have to monitor these things closely when we adjust the diuretics. Sometimes even that's not enough, and then what we need to do is to drain out the fluid from the belly and the abdomen, and we call that paracentesis. So this is a procedure where the ascites fluid is removed via a catheter, and we can take liters of fluid off at one time. But we have to be very careful, because if we take too much, that can cause fluctuations in blood pressure, and that can be a problem for the kidneys. So the important thing to know is if you ever require a paracentesis, that albumin should be given with it. And albumin you usually notice is in these tiny glass bottles, and it looks like a yellow liquid. But what we're doing is we're giving protein back to try to keep the fluid where it should be in the blood vessels and avoid those shifts that can be a risk for you. And a paracentesis can be helpful to relieve pressure, but each time it's a risk. There's a risk of bleeding, there's a risk of infection, so we don't really want to be doing these things all the time. I mentioned that the fluid can become infected, and we call that spontaneous bacterial peritonitis. So, this is sort of when you get bacteria, most often from the gut, sort of leaks into the fluid in the belly, and that can be dangerous. It requires antibiotics and it requires treatment with albumin as well to try to protect the kidneys during that time of infection. Once a person resolves the infection, then we prescribe antibiotics to prevent another episode. And sometimes patients may benefit from being on antibiotics to prevent an infection in the first place. And we as doctors determine that based on analyzing the fluid. So I should have mentioned when we do paracentesis, it may be diagnostic, where we take a small sample to analyze, or it may be therapeutic. And therapeutic was what I was talking about when I said that we can remove liters of fluid at one time. So the next thing that may happen when a person has portal hypertension or that high pressure traffic jam situation in the liver is in something called encephalopathy. And encephalopathy refers to a change in thinking from a buildup of toxins. And generally that toxin is ammonia. And that's because when the blood is being diverted, then it's not being cleansed as well by the liver, and you can see higher ammonia levels. Um, and this can present in very subtle ways. It may present as a change in sleep-wake cycle that you may find that you are sleeping more during the day and not able to sleep at night. It may result in slowed reaction time, slowed or slurred speech, and then to the point of confusion, disorientation, and may even lead to coma. So the important thing is that we recognize it and try to bring the ammonia down to prevent that sort of progression and symptoms. Encephalopathy makes driving unsafe because it slows reaction time, and we really encourage patients not to drive if they're struggling with encephalopathy. So there are certain things that may trigger the ammonia to build up more rapidly and create an episode, and that may be bleeding, infection, dehydration, constipation, pain medications, and other sedatives. So it's important to recognize that and be on top of it to prevent an episode. So how do we treat encephalopathy? Like I just said, we want to avoid and address triggers. Um, then we also have medications that we can use to try to lower ammonia. One of those is called lactulose. It's a sweet liquid medication. It doesn't taste that great, but it's really important. What it does is it helps people to poop out extra ammonia. So it has a laxative effect, but it also binds the ammonia out in the stool. And when you're using lactulose, the goal is to have about around 3 soft stools per day to really be adequately eliminating ammonia. You can't overdose on lactulose, but what can happen is if you have too much diarrhea, that can result in dehydration and make things worse. So you really want to adjust the dosing to achieve that goal of 3 poops a day. Sometimes we have to use other laxatives to help things along as well. And then we have an option to use a medication which is called rifaximin or Xifaxan. It's an antibiotic, but it's not absorbed from the gut, so it stays there, and it works by reducing the bacteria that produce ammonia. So sometimes we may actually use these medications together. Um, so I talked about some of the treatments that we have for ascites, fluid buildup, and varices or varicose veins that may result in bleeding. If those treatments fail, then we may consider something called a TIPS, which is a sort of shunt. That stands for transjugular intrahepatic portosystemic shunt. And this procedure is often done by interventional radiologists. What they do is they go in with catheter based therapy and they create a shunt or a connection between the blood vessels in the liver, namely a branch of the portal vein coming in and the hepatic vein coming out. and that's to create a sort of bypass track so that you reduce pressure. And when you reduce pressure, you can reduce the tension in varicose veins, and you can reduce the tension that's leading to fluid buildup or ascites in the belly. But unfortunately, this doesn't come without any risk. When you do a shunt, you're again bypassing some of the filtering of the liver, and that may lead to more ammonia buildup or more frequent encephalopathy episodes. It can also be dangerous if the liver is really very sick, because the reason why you can divert some of the blood flow is that the liver also has another blood supply from the hepatic artery, which isn't shown on the screen here. And so that's why you can often do this and the liver can handle it. But if the liver is really very sick, that may precipitate things to get worse. The other thing is that you're bringing more blood back to the body and the heart more quickly. And so if the heart is weak, that may be dangerous. So if we need to consider this, it has to be a careful assessment with your doctor and some testing beforehand to make sure that it's going to be safe. So I want to talk now a little bit about liver transplant. So liver transplant means removing the scarred liver and replacing it with a healthy liver. Um, and that healthy liver may come from a deceased donor, someone who's passed away, and they themselves, before their death, or their family, or the combination has decided that they're going to give the gift of life and donate their organs. Or it may come from a living donor, a healthy person who decides that they want to give a portion of their liver to somebody. Believe it or not, the liver is an organ that can regenerate. So if a living donor does that, the liver will regrow to full size in the donor and recipient, usually within about 6 to 8 weeks. Um, so a liver transplant in that way is an operation that can be a cure for advanced liver disease. But of course, it requires treatment then lifelong to protect the new liver, medications to prevent rejection, and close monitoring with the transplant team. Um, but unfortunately, right now, it's the only cure really for decompensated cirrhosis, because there's no medications that can reverse the scarring or restore liver function. The medications that we talked about are really to try to control the complications. So when a person has a significant liver dysfunction or liver failure, again, which we may objectively assess with the MELD score, or if they have complications of portal hypertension like ascites, varices, encephalopathy that can't be controlled, or develop a liver cancer, then that's a reason to be considered for transplant. And there are other more unique scenarios which are beyond our discussion today. If you're referred for a liver transplant evaluation, the goal of that evaluation, or the questions that you want to be asking, is my liver disease severe enough for me to need a transplant? Number one, will I be okay in the operating room and recover from a major surgery? So that gets to looking at overall health and making sure that you're optimized to um, undergo that operation and recovery. And then, will I live a long life with my new liver? Meaning, is the health otherwise okay, that's the expectation? Because when a person has a liver transplant, the expectation is they live many, many years with that new liver. Um, Long-term survival now is excellent due to advances in immune suppression and overall care. The important thing to realize is that liver disease may not be predictable. So if a person has decompensated liver disease, that's really the point to be referred, and you should be talking to your doctors about being seen at a transplant center. So I just want to review now an overall strategy for management of liver disease, which relates to a lot of what we just talked about. So first, you need to identify and address the cause of liver disease. So for example, if somebody has hepatitis C, you want to be addressing that with antiviral medications. If somebody has non-alcoholic fatty liver, you want to be addressing that with weight management, control of blood sugar, blood pressure, cholesterol, etc., because you want to try to stop the hepatitis or inflammation and stop the scar progression where it's at. You want to understand the stage of liver disease, so understand where on the spectrum of hepatitis, fibrosis, cirrhosis, compensated versus decompensated you stand. And then look for and treat complications, varices, ascites, encephalopathy. Screen for liver cancer again every 6 months if there is one found, to treat it. Complete alcohol avoidance because alcohol damages the liver. Even if it's not the primary cause of liver disease, alcohol intake can be a second insult and should be avoided. Adequate nutrition is very important because, as we talked about, the liver is not able to make albumin and other proteins and cholesterol like it normally would. So it requires a real effort on taking in enough calories and appropriate nutrients. Vaccinations, we have certain viral infections we can protect against. That's hepatitis A and B. So all patients should be vaccinated if they haven't already been exposed. And then yearly flu shot because, as we said, the liver acts as part of the immune system, and when it's sick, people are more prone to infections. And then appropriate consideration for liver transplant in the right setting. So what can you do to improve your liver health? Take medications as prescribed, monitor response, which we'll go into in a little more detail, communicate regularly with your doctor, educate your care partners about disease signs and symptoms. Like we talked about, it's really important to pick up on early signs of ammonia buildup or encephalopathy. Avoid all alcohol. Take medications only that are safe for the liver. Acetaminophen or Tylenol is actually safe in the recommended doses. For a person without liver disease, that's 4,000 milligrams a day. But for somebody with liver disease, it's 2,000 milligrams per day. So an extra strength tab is 500 milligrams. That would be up to 4. But Tylenol should never be combined with alcohol, and it's important to note that it may be in other medications such as Dayquil combinations and things like that. So you have to look at labels. Generally, when a patient has portal hypertension, we say to avoid non-steroidal anti-inflammatories. That's ibuprofen, things like Motrin, Advil, naproxen, Aleve, because that can add a second stress on the kidneys that are already stressed because of the high pressure and fluid buildup in the belly. And avoid herbal supplements which may not be regulated and may cause liver damage. Make sure you get adequate nutrition, stay active, maintain a healthy weight, follow a low salt diet, do exercise, even if that's just walking, to stay mobile. It can be helpful to actually create a chart that helps you track your weight, salt intake, water pill dosing, blood pressure, and heart rate, so that your doctor can help you adjust the water pills or beta blockers for prevention of variceal bleeding, and then to track bowel movements to make sure you have appropriate response to lactulose and not prone to ammonia buildup. So I hope that this webinar will help you to better partner with your doctors to optimize your care. And I want to thank the American Liver Foundation again for sponsoring this webinar. Thank you.
Thank you, Dr. Liapakis. I think Dr. Liapakis has a wonderful skill of taking a very and making it very understandable. And every time she speaks, I learn something new. So thank you as well. These are some of our resources that you can take advantage of should you need help. Again, we have this helpline that can give you additional information if there's anything that you're interested in delving into a little more detail. Our Connecticut office phone number is 203-234-2022. And again, we want to thank Yale New Haven Health for their generous sponsorship of this webinar. Thank you so much for listening.